Well, welcome to the final session of Rio 2022. Devi, Mintu, and Karina are not being let off the hook yet. We're asking them to stay with us for this final session. And I'm really looking forward to the presentation, Emerging Technologies for Arrhythmia Detection and Disease Management, which we're going to get Mintu to give us. And I'm really looking forward to your presentation. Over to you, Mintu.
Thanks again. Thrilled to be here. Thank you all for staying until the end. And I want to thank Debbie, Rod, and the organizers for letting me chat about this. This is going to be a high-level overview of where I think we might be going with these emerging technologies. These are my disclosures, and many of them are relevant for this. So these were the first two medically cleared watches back in the early 90s. They never had broad adoption, and this was not in the consumer space. This was actually direct as a Holter alternative with billing and reimbursement around it, but it never really picked up. We then kind of went forward all the way from the first consumer watch, which is the Casio watch from 1991, claiming to measure ECG and blood pressure. It wasn't very good for either one, but you can see obviously where we've come in a very long way. We do know that wearable ownership globally is going up. These are estimates in the US from survey data that we do at Stanford with Rock Health on the right and some other market estimates. We think that the global population, at least Europe and much of Asia, tracks this as well, including the market share. But I think the key observation is what I'm sort of now calling the fact that we're going backward in time, and we can talk a bit about in the discussion. So today we have a bunch of really phenomenal consumer devices that can look at irregular PPG for AFib. They can record an ECG, but they're not cleared for disease management in established patients with AFib for the most part. And so what's happening now is we're kind of going backward to these earlier watches that were really designed to be medical grade, with a number of companies starting to explore or enter this space. What we don't have are the use cases, the workflow, and the technology stack. And I'm not going to have time to talk through software solutions for disease management in AFib, but I think that is an unmet need in the discussion. So there's a lot of options for assessing AFib burden. And I apologize if there's some sound. It just so happens that a leaf blower has to come on at the time that I'm giving this across the street. But here is the matrix between ECG and PPG on the left and continuous or semi-continuous versus intermittent on the right. Obviously, we have insertable cardiac monitors and cardiac rhythm implantable devices here, and I'll start there. Insertables are very good. The positive predictive value for AFib was actually not very good in early generation devices, but in second generation devices, they're much higher. And these tend to work for longer episodes of AFib, which is probably okay, since those are the clinically actionable and clinically important ones. If you get to intermittent ECGs, as we all know, there's a ton of these on the market. You think through the 12-lead ECG, and that has been generalized to a left arm, right arm, lead one ECG across a range of form factors. Some companies like AliveCor also offer a 6-lead ECG. There is a lead on the back of that device touching the leg that now gives you 6 channels of information. And if you use this ad hoc approach to assess for AFib burden, it's not bad. This is from the mSToPS data. This was a screening study, and what the group did is they found that in model data, twice daily ECGs over a 2-week period generally catches AFib burden greater than 5%. So that's not bad as long as patients can do that. And again, that presents a solution. If you look in intermittent PPG, there is one solution, particularly in Europe, that's gained a lot of traction, which is FibraCheck. And the idea is transillumination of the finger from the light on the phone, which happens to be next to a camera, gives you in both heart rate and irregularity that can be used for overall disease management. And again, this company, to its credit, along with Dominic Linz and others, have built disease management technology stacks that have been in clinical programs and in trials in parts of the EU. When you get into pulse checking with a semi-continuous state, you end up in the domain of watches. And I'll talk about wearable technologies. They give you 3 streams of data. One is continuous, where you get overall beats per minute. You don't get true ICM or CIED-like AFib burden. You then get episodic data capture with a non-continuous ECG of 30 seconds. And then as clinicians, we deal with all of the alerts and the notifications and what to do with them. The pulse checking is in the background for whether it's the Apple device or any other device. And when there is good skin, electrode, and photodiode contact, it can start sampling during periods of inactivity. And these are generally tailored for specificity. So they're looking at a cluster of irregular tachograms to identify AFib. That's true with Apple, that's true with Fitbit, that's true with Huawei, which are the three main out there across the world. That being, and their positive predictive values are quite high of 82% and upwards. The important and interesting unmet technology need, though, is that they're not all approved for AFib management. Most of the PPG AFib detection algorithms are currently positioned as pre-diagnostics for patients without a history of AFib. And that serves a very important purpose for identifying undiagnosed disease. But what about the people who have AFib, and what technologies do we use? What should we do? Well, the consensus statements still say we should be sticking to ECG at a minimum for diagnostic rhythm determination. Here is the onboarding from Apple. They've done a very good job on AFib burden. They call it AFib history. And this is a feature for patients with established AFib. It is over the counter. It is, again, not intended for medical use, as you see, but it's nice to give patients what they need with their AFib history. The temporal resolution is that it'll tell you that your AFib is 2% or less. It can't tell you, at least in the intended use here, that you're 0%. So it doesn't tell you definitively had not had AFib, but it'll say that it's below 2%. Again, that is very helpful to many of our patients and certainly has value. On the medical side, there's multiple watch companies coming into play. I'm involved in one of them, but Pulson and Corsano have had some interesting designs and technologies that have worked in Europe in various parts. Corsano also has an ECG from the frame, the metal frame, as well as an electrode on the back, and these also have the capability of doing a variety of things. So again, the key difference is that these and many other devices are looking to be medical grade disease management solutions and not in the clinical space. And whether it's one watch or the other, you find that they do quite well when they are indexed to ambulatory ECG monitoring down to an AFib burden estimate of 0. In order to have that high resolution, what you may have to do is tie the irregularity or lack of irregularity to the ECG. So prompting the patient to take ECGs at periods of wear to increase the sensitivity, specificity, or in this case, positive and negative predictive values. But again, that is a workflow that can be used and has shown feasibility. I think 10 years from now, it may no longer be in the wearable or patch domain. And so this is some interesting work that is with the group by Ben Friedman in Asia, where they looked at using an off-the-shelf but high-quality video camera put on, in this case, cohorts of 5 patients at a time or participants, shown that facial plethysmography can get you heart rate. And if you can get heart rate, usually you can get irregular pulse or pulse rate. You can usually get irregular rhythms as well. And they showed that you can do this contactless directly from a camera. So we can live in a world where you might be able to do this on your telehealth call with the patient's own camera. And again, this is this idea that we may be moving away specifically from wearable devices, so to speak, over the long haul. Those technologies can also be applied in the kiosk fashion. These are 2 pilot examples, one in China, one in the US, of care stations, which could increasingly take on these diagnostic capabilities, whether it's electrode-based or not. So now you get into the kiosk part where you don't necessarily need to be at a hospital. So you could imagine a whole suite of diagnostics that are available, that are easy to get to, no differently than a cash machine from a bank machine all over, where you do your diagnostics. You don't need to go see your doctor to get the physical exam, but the doctor is then available for telehealth remotely. There's also some work that's been done in the wellness space. This is from Panasonic, looking at contactless vital sensing, starting with heart rate. This was used for athletic performance. It's amazing to see that in this video of a professional archer, his heart rate goes so high. But again, they're using this for athletic performance, certainly can have medical grade applications. And there's new technologies that are moving beyond direct video to impulse radio and ultra wideband radar. So now this is using radio waves and radar to guide the detection of AFib. This has been done in several domains: wireless telemetry or contactless telemetry in the hospital, assessing the vital signs of a pilot or a professional driver, or even a regular car driver, just to look if the person is stable, as well as in sort of medical applications. So again, today we talk about things strapped to our chests and our watches, but tomorrow there is much more potential for these technologies to mature and enter the healthcare space. So I'll close to say that there are many wearables on the market worldwide. Most of the algorithms are over the counter and not cleared for clinical diagnosis or treatment. There's a suite of new clinical grade wearables emerging, which will likely have EU MDR and FDA clearance for disease management, and less about a pre-diagnostic and more about something we might use as a tool for a diagnostic. We may be with wearables today, but there might be much more to come tomorrow, and I've given you a preview. There's a lot of gaps we could talk about in the discussion, such as having the technology stacks and the disease management to get AFib treatment early, such as rhythm control, in my view, more so than anticoagulation. And can we get that way upstream of electrophysiology or even cardiology, enable primary care to do that? What are these use cases? What should they look like? What about reimbursement for adoption? And obviously, we need high-grade evidence for these technologies, and there are some trials in development. Thank you.
Mintu, thanks. That was really fascinating and really exciting. I wanted to start with a sort of philosophical question, really. It seems to me that these over-the-counter event recorders have really helped enormously in making the diagnosis. But I'd like you to sort of expand on the idea of disease management, because if the symptoms are not there, why does it matter how much AF you have? Well, tell us about why these devices are important.
Yeah, so even before we get to the devices, what do we know? Well, we know that anticoagulation prevents stroke. We've trialed that. We've seen stroke stop, Danish loop, so many other trials. A few are ongoing. And we found minimal effect reductions in stroke. The p-values were significant in stroke stop, but the absolute risk reduction, quite honestly, wasn't as much as everyone would have wished for. And there may have been some barriers there, such as optimal anticoagulation. But the other thing is the overall stroke event rate in patients with AFib and in patients without AFib has gone down, at least in industrialized countries. What we know, though, with EAST and CASTLE and a number of trials looking at early rhythm control, is that you can severely alter the trajectory of development of heart failure specifically, and maybe other broader cardiovascular events. So that becomes critical. That may get us to thinking of early rhythm control quite early and aggressively. And then again, if you have a consumer device where someone's putting it on and they're not getting the care that they have, that short episode of AFib may not be clinically consequential directly, but maybe it's the front door for cardiovascular risk factor management, assessing blood pressure, diabetes, cholesterol, sleep disorder, breathing, and putting that whole package together. So I think that's where the opportunity is more globally, is overall CV prevention with an eye toward heart failure. Anticoagulation is great. Obviously, we all believe in it, but I don't think that's the only intervention or the one that's going to show the outcome differences.
Well, that brings us on. I mean, I often say to patients that AF can maybe the thing that saves your life, because it makes you do things that are good for the more serious cardiovascular diseases. But it brings us really nicely on to Karina's view about this, because Karina, what's your view on the AF disease management and the use of these wearables?
Yeah, well, you talked about primary prevention in a way. Or so I'm thinking of all these patients undergoing AF ablation and are at low risk for stroke. These devices may help us to select those that may sort of withdraw anticoagulation post-ablation if there is not atrial fibrillation recurrences. Another population is, of course, the heart failure patients undergoing ablation. How do we monitor these patients after an intervention? How can we make sure to detect recurrences, but also AF burden, to monitor the AF burden? We've seen from the CASTLE AF trial that if you have over 50% of AF burden, you have an increased mortality. So you would have to know when to do the re-ablation to sort of keep the low mortality rate according to the trials.
That's a really important point. And Devi, I know that you, your practice is pretty interesting because you support the local emergency rooms to help get patients a diagnosis quicker using more traditional things like Holter monitors. Are these sorts of wearables something you're increasingly using to increase diagnostic yield?
So we are using a lot of off-the-shelf equipment now. I mean, I would say, our patient charts are filled with Apple Watch recordings and cardiac recordings, and so I think we are seeing a large uptake of these technologies in our area as well. Having said that, I think the more where I'm starting to use them is in post-ablation management, to look at not just recurrence, but look at AF burden as a marker of when do I go back, when do I re-intervene in those patients that I've ablated in the past. So I feel like I'm not targeting every little recurrence anymore. I'm looking at it more as a burden rather than just one episode. Mintu, I know you kind of touched upon this, but one of the challenges that we face is all the data burden that comes to us, and I have not been able to put it together in a way where I can manage it appropriately. I feel like I'm not doing a good enough job. Do you feel like do you anticipate algorithms and AI algorithms to help us make this a little better? Because the way the current situation is, on an average, we'll get about 100 to 120 tracings every day from smartwatches and the cardio devices on our inbox.
Yeah, it's a great question. I think that there's a couple issues. One is the data deluge, right? There's just too much of it, and what do we do? So to me, that's a structural problem in the fact that the reimbursement hasn't matured, at least in the US. So we have remote patient monitoring. Remote patient monitoring was generally intended for hypertension, weight, diabetes. It's not extended itself into the AFib domain. Typically for RPM, they also, you're using devices that can have medical clearance, although we are seeing some wearable uptake. So what happens is when the patients just keep emailing you or uploading their ECGs in the portal, it's hard to assess. And then on the technology side, we don't have this like single source of the AFib journey of the patient, starting from their first episode to a watch, to a Holter or a patch monitor, to a pacemaker, to an ICD, right? Like we don't have the entire history. That may come, I think, as the data gets more integrated or simply from EHR determinations, and there's companies doing that. But I think what we just don't have is an incentive in the US with a fee-for-service system to make sure that we're actively surveying our patients. We manage to do this in our EP programs because we build them to be resourced. We have great nurse practitioners. We know the patients, as Karina said, that are at risk with asymptomatic AFib, that if it comes back, they slide into heart failure. But that is the unmet need. And so obviously there are many companies and groups working to think through new payment models for this. On the Medicare Advantage side, with value-based care in the US, there are claims to be made and experiments to be done where you could do this and it will lower overall utilization. But in the bread and butter patients that we see, as you know, we just don't have it yet. So I'm optimistic that that will come, but it'll take some time.
And Karina, risk reduction in AF is so important, weight loss, alcohol reduction. Do you think these wearable devices will give patients enough immediate feedback to reward them for their efforts? Will AF burden go down if they lose weight? What's your view on that?
Well, that would hopefully be so. I'm not so sure that patient would sort of use that as a positive feedback. Possibly, it would be interesting to conduct such trials. It would certainly be interesting. I don't know. Short answer.
I think that one of the advantages of having patients see their AFib data is it puts them on the hook. Both to be accountable for their behaviors, but even so, the return of information is very motivating. And what we're seeing with some of the AFib history measures in the consumer space that I showed, with one of the watches, they're actually trying to tie that back to the other lifestyle measures. So they're trying to correlate that with sleep, with exercise, with activity. And so, again, to the credit of the consumer space, they're leading in this area much more than we are. So perhaps all of that, if we can package it in a way that motivates patients to do the right things, and burden becomes one of those targets, with, again, the great work that Prash and others have done, maybe that's an opportunity.
But still, if we're talking about non-heart failure patients, it's still the symptoms that governs our treatment. So
right.
If patients have symptoms, we'll use the monitoring to confirm they have AF, but we don't use the monitoring unless the patient have recurrence of symptoms.
So this opens a whole new and interesting thing, because Mintu has referred to the East and Castle trials that suggested that rhythm control, early rhythm control, may have prognostic benefit. But to your mind, Karina,
sure. But I just want to make a comment. Sure, we don't know about how early is early. We just know that rhythm control is preferred as compared to conventional treatment, because that is actually what the East trial did study. They compared rhythm control with conventional treatment because both arms were early. And we don't know what is early. How early? Is it the first episode, or is it within 1 year?
Well, there's a whole, I must say that I'm a conservative like you. I'm still a symptom-driven therapy deliverer, so I must agree with you. Devi, finally, you inferred, and this is pretty interesting, that your conversations with patients may be changing when you're talking to them about ablation, perhaps influenced by these wearables, in that you're talking to them about burden rather than absence of AF. Is that, have I put words into your mouth, or is that true?
I think that's exactly kind of where I'm going. I think I believe that as we're seeing new trials, we're looking at, for follow-ups, we're looking at more burden as an outcome rather than just recurrence of events. I do believe for patients too, especially not in the early rhythm control. This is not the de novo patient that I'm talking. For a patient that's already had maybe one round of ablation, as the disease is progressing, many times they're not symptomatic. So, I'm also a very symptom-driven delivery person. So for me, just because the patient has an implantable or a pacer and we catch some AF, I'm not too keen on taking them back into the lab, especially if they feel fine and they're happy with how they are progressing, as long as they don't have heart failure. Now, if I see that the burden's going up, then that even if the patient's asymptomatic, now that's concerning to me, that maybe they will be heading towards heart failure, and I probably will talk to them about intervention, even though they're not symptomatic. and now wait till they become symptomatic. So that's kind of, I think, the early, easiest way for me to put it.
I agree. I mean, and so, Jason Andrade, who was on in the VT session, he's done some extraordinary work trying to better clarify the relationship between AF burden changes and improvements in quality of life. And from, a lot of the cryo data that he's done, he's shown that even among people with low burden AFib, getting it even lower to 0 can meaningfully improve quality of life as measured across multiple AF specific and non-AF specific instruments. We also know from early AF and the more recent sub-studies looking at AFib progression, there is something to be said about thinking about rhythm control with the outcome of progression. And so there's sort of two issues here. One is, as Devi said, I think clinically, when we frame AFib ablation to our patients, we really talk about quality of life and burden reduction plus the heart failure component. But I wonder, in the trial paradigm, if we start thinking through of progression as an outcome that we start to prospectively evaluate, and curious to hear what the others think of that.
Well, I'm afraid we don't have time to go into this any more detail because we've run out of time, but this has been a fascinating discussion about the philosophy of atrial fibrillation management and how the technology has changed that. I'd really like to thank again Devi, Mintu and Karina for their amazing contribution to this session. And it's now time to wrap up for the course. Well, as we approach the end of Rio 2022, I'd like to reflect on the successes. We've had a global faculty of over 40 of the leading physicians working in electrophysiology today who universally made me look pretty average. So I'd like to thank them very much. We've had 3 days of live broadcasts, 5 hours or more each day with a focus on ablation and occlusion, mapping and imaging, and finally therapy and technology. We've had live and pre-recorded cases from my hospital, St. Bart's here in London, CCB, Marcus Krankenhaus in Frankfurt, St. Bernard's, Heart and Vascular Center in Arkansas, Centro Cardiologico in Milan, St. Antonius Hospital in Nijmegen, and the University of Arizona College of Medicine in Phoenix. We would like to thank all of these centers and their teams for allowing us access and being so accommodating for our video teams. On that note, I'd also like to thank the case operators, Boris Schmidt, Julian Chun, Devi Nair, John Yap, Saeed Hassan, Claudio Tondo, Ross Hunter, Lucas Bosma, and Roderick Tung, and of course their teams. And my thanks extend also to my fellow course leadership, Devi, Julian, Jason, and Roderick, who've worked really so hard with me to create a program that we feel offers a real-world practical benefit. And that's the underlying goal of Rio, to best support you, the healthcare practitioner, achieve the best possible clinical outcomes in your electrophysiology practice. It remains Rio's goal to weave a fascinating and challenging program with immersive virtual environment to create a uniquely engaging and interactive event. We hope that you agree that we've met this goal. It is also our philosophy to ensure that the free to access nature of all sessions, disseminating CME accredited learning as widely as possible to the global electrophysiology community. On that, please don't forget to claim your CME credits. With well over 2,000 unique attendees, I believe we've met that goal. Of course, without our industry partners, Rio could not exist in this model, and therefore I would like to thank our headline partners, Boston Scientific and Medtronic, our partners, Abbott and AtriCure, and our supporting partners, Biosense Webster, EBR Systems, and Volta Medical. I would also like to thank Radcliffe Cardiology for facilitating such an amazing event. All sessions from this, and indeed previous iterations of Rio, can be found on demand on radcliffecardiology.com, a knowledge network for the cardiovascular community comprising thousands of free-to-access educational resources. We first launched Rio in 2020 during the peak of the pandemic, and since then it's grown year on year. The world reopening and on-site congress returning has certainly not dampened the appetite for Rio, and I believe it's now established itself as one of the key practical events in the electrophysiology calendar. Indeed, we've experienced double-digit growth each year in attendees, and feedback has been wonderful, which has certainly been a source of inspiration for me and no doubt my fellow course leadership. With the on-demand availability of the sessions, the educational value extends far beyond these days, and we believe Rio has a truly lasting legacy for practical improvement. Therefore, it gives us great pleasure to announce that we will return with Rio 2023 taking place on the 29th of November to the 1st of December 2023. It's our intention to return bigger and better than ever, so look out for new developments. So wherever you are across the globe, from me and my fellow course leadership, we thank you so much for joining us, and we'll see you at Rio 2023.